Good evening, delegates and faculties members. Thank you for joining Shield Connect. And today we are back with our famous series, Icons in Conversation with Dr. Ritu, which is sponsored by Dr. Ritu Santwani ma'am. So today the topic is ART pregnancy, how to tackle it. And today icon for the day is Dr. Sunita Chandra ma'am. So before we start with the session, let me give a quick introduction of our ma'am, Dr. Ritu Santwani. Ma'am is obstetrician and gynecologist, IVF specialist, and founder and CEO of 360 Degrees Healthcare Studio. Ma'am is also consultant at Inamdar Multi-Speciality Hospital in Pune. And ma'am is infertility test tube baby specialist. Ma'am has also been part of NUHS Singapore, co-founder of MAAM and board member of SWWC. So I also welcome Dr. Sunita Chandra ma'am, who is icon for today's session.
Nishant, 1 minute, please check. Madam has joined. We are introducing the madam. Madam, are you there, Sunita madam?
I'm here. I'm very much here. I don't know.
Okay.
Video.
Acha, okay. No issues.
Okay,
Yeah, Nishant, please continue. Nishant, please continue.
Okay, ma'am. So Dr. Sunita Chandra ma'am has done MBBS, MD, FICOG. Ma'am is director of Rajendra Nagar Hospital and IVF Center, and also of Morpheus Lucknow Fertility Center. Ma'am is advisory board member of IFS UP chapter. Ma'am is chairperson of Medico Legal Committee of Lucknow Obstetric Gynecology Society, and ma'am is also member of Quality Council of India. So I welcome Dr. Sunita ma'am and Dr. Ritu ma'am for this wonderful topic that is going to be covered today. So I hand over session to Dr. Ritu ma'am. Thank you so much.
Yeah. Thank you, Nishant. So first of all, a very warm welcome to all of my dear friends who have joined all across the geography. I'm able to see so many of my friends have joined from the different countries. A very warm welcome to all of you. And in our India, we have just celebrated our very auspicious festival. So once again, happy Diwali to all of you. So friends, as we all are aware, the ART pregnancies is always a dilemma in the, not only in the patient's mind, but also in the doctor's mind also. So what are the complications are coming when we are dealing with the ART pregnancies and how to deal with that? There is one misnomer in every patient's mind, ma'am, if you are going for the ART, either IUI or IVF, is it must that the delivery should be only by the cesarean section? Can't we go for the normal delivery? Other very important dilemma in everyone's mind, because in the while we are going with the ART techniques, mostly either the twins or the triplets, is it necessary to put the stitch os tightening to each and every patient? What are the recent studies suggest? So now, like this, there are so many different points to ponder for while we are tackling with the ART pregnancies. So today with us, the stalwart from the Lucknow, Madam Sunita Chandra is with us. Madam is awesome orator, and we are thankful to the madam that madam has accepted our invitation. So madam is going to discuss with us today that how to deal with the ART pregnancies. Friends, the program is going live on YouTube. So all of you can post your queries either here or on the YouTube. After the madam's lecture, we can discuss the questions, whatever we receive. So over to you, madam. Yeah, good, ma'am. Now we can see you. Yeah. Good evening, madam. Good evening.
Good evening. I'm so sorry for.
No problem, ma'am. No problem.
So first of all, Ritu, thank you so much for bringing me here. I'm really, really grateful that I'm here on this prestigious platform. And now, although it's late, but delayed Diwali greetings to all of you. I bring Diwali greetings from city of Nawab, Lucknow. And I really welcome all of you on this today's webinar. So the topic for today is ART pregnancies, how it is different. Okay. So,
yes.
So why are we worried about ART? Why are we worried about ART pregnancies? So every pregnancy is a pregnancy, but why we are worried about this ART pregnancies? Because all of us are at distress. The patient, the doctor, and the attendants, because it's a ART pregnancy. I think you can see my screen properly.
Yes, ma'am. Yes, ma'am.
Yeah, okay, okay.
Yeah.
So why actually we need ARTs? Because if you see the data, this is continuous decline of fertility. If we are tracing from 2018, so we can see that there is a decline of fertility, and that is actually important to know that our fertility rate in India is on continuous decline. That is why we need something like fertility treatment. So whether it is ovulation induction and IUI, or it is IVF, or it is ICSI, frozen embryo transfer, self-X, donor-X, self-sperm, donor-sperms, and so on. But we definitely need these ART pregnancies to have a balance between the couple who are not having a babies and the couple who are having baby. So at the end of the day, you want to give a baby to every couple, because that is what makes them happy, and the social stigma which is attached with infertility does not go unless they have a baby. WHO actually estimates that there are between 12 to 16 crores couple struggling with infertility worldwide, and this is the burden all over the world. If we talk about India, it's really high. Almost 14 to 16% couples are struggling with infertility, finding it difficult to get a baby. If we talk about IVF, so around 1.5% pregnancies, deliveries are by IVF, and that amounts to 1,30,000 babies per year. And out of these, multiple pregnancies are 40,000. That is 30% of IVF pregnancies are multiple pregnancies. Management of these pregnancies is difficult, as the couples and treating doctors have undue concern and apprehension and worry about outcome of such pregnancies. And the distress is not only on the attending doctor or on the patients, but there are so many attendants with them who are under distress, and they make you under distress. So that is why ART pregnancy is a difficult pregnancy, or maybe a different pregnancy. Counseling is very, very essential in these kind of pregnancies, because you know that risks are associated with the ART treatment per se, and then ART pregnancy. And you need to know any maternal existing disease, pre-existing disease like hypothyroid, like diabetes, hypertension, which was pre-existing, or she's taking some kind of medicine for, say, for depression, for autoimmune diseases, and so on. And nowadays, we are getting lots of cancer survivors also, especially breast cancer, who get breast cancer in their young age, and the transplanted patients. I have got a patient of liver transplant, kidney transplant patients now are actually coming frequently. So we have all these kinds of patients which are at high risk otherwise also, and if they go for ART, they are at high risk. So if we talk about symptoms of ART pregnancies, so you can see the symptoms of normal pregnancy or ART pregnancies are almost the same. It's just that if you have had this pregnancy by self-stimulation cycle, and if there was slight ovarian hyperstimulation, this may have little more symptoms like bloating, like lot of nausea and vomiting, and fluid retention feelings, all these things, and abdominal pain may be more in ART pregnancies in comparison to normal pregnancies. Otherwise, all the symptoms like nausea, vomiting, backache, constipation, everything is almost the same in initial part of the pregnancy. But there are multiple papers which say that ART increases the risk of adverse maternal complications such as GDM, preeclampsia, and intrahepatic cholestasis of pregnancy. So we have to reduce the doses of gonadotropins and exogenous progesterone, because Ritu and everybody here will agree with me that we are seeing lots and lots of patients with intrahepatic cholestasis of pregnancy in early part of pregnancy. That is around 10 weeks, 11 weeks, which is really bad. While we used to study that intrahepatic cholestasis of pregnancy comes from 22 weeks of pregnancy, but now we are seeing from 10 weeks onwards, 11 weeks onwards. This is all because of high hormones, which we are giving in terms of estrogen and progesterone support. So we have to really look into it so that we can reduce the complications related to intrahepatic cholestasis of pregnancies. So if we see adverse pregnancy outcome in ART conception versus spontaneous conception and single versus multiples. Multiples actually have adverse outcomes whether it is ART pregnancy or naturally conceived multiples. They have similar outcomes. Multiples are more in comparison to single pregnancy if the pregnancy is due to ART. This we have already seen. Single pregnancies, if it is through ART, in comparison to naturally conceived single pregnancy, they have higher adverse outcomes if the pregnancy is with ART. So if a lady has conceived naturally, she has a single pregnancy, and the other who has conceived by ART has a single pregnancy, she definitely is more prone for adverse outcomes, for maternal fetal complications in comparison to a lady who has conceived naturally. So if we see complications, I mean, this was a very nice paper in 2016. The commonest complications was multiple pregnancy, as I've already said. Incidence of twins was the highest, and these pregnancies may have vaginal delivery also. So actually this paper said that IVF ET per se is not an indication for cesarean sections. They can have normal deliveries, although they should be treated as high-risk labor cases. Multiple pregnancies, incidence is 30 to 50% as against 3 to 4% conceived naturally, mostly multizygotic. This is actually a better thing in comparison to spontaneous conceived twins. Monozygotics are very less. It is MCDA is increased rather than MCMA. The cause of multiple pregnancies are extended duration of culture, embryo manipulation, ICSI, and transferring more number of embryos and hatching. If we talk about fetal adverse outcomes, then early pregnancy loss, all of us know, very early pregnancy losses are there. Spontaneous abortions are more, ectopic pregnancies, congenital malformations, preterm birth, low birth weight, small for gestational age babies, stillbirth. I'll come to them one by one. And in maternal, if we talk about adverse outcomes, then it is pregnancy-induced hypertension, gestational diabetes, premature rupture of membranes, and so many complications related to placenta, like placenta previa, abruption, vasa previa. Cesarean deliveries are definitely more in comparison to spontaneous conception. And overall, perinatal mortality increases and severe maternal morbidity is there. There is increased rate of antenatal admissions, like spontaneous conception patient hardly comes to your hospital admission, but these patients are admitted again and again, sometimes for his early trimester bleeding, sometimes with preterm labor, preterm rupture of membranes, all these things, or maybe very high blood pressure, sugar levels are very high. And because of preterm labors and small for gestational age babies, rate of an ICU admission is definitely more. So if we talk about early pregnancy complications, early pregnancy loss, that is very early pregnancy loss and early pregnancy loss, both are very high. What I mean with very early pregnancy loss, where the UPT, urine test is positive, beta HCG was good, but suddenly patients come. I mean, the day you get her UPT is positive, beta HCG was somewhere around 1000, and in 3-4 days they come with bleeding PV. So these are very early pregnancy losses where the sac has not formed and pregnancy and the patient starts bleeding. Early pregnancy losses again are much more common. Repeated episodes of bleeding PV may be in first trimester, second trimester, third trimester. First trimester because of threatening, second trimester because the placenta is going down, or maybe because of placental abruption in late trimester, or maybe something like placenta accreta percreta. Spontaneous abortions are more, and ectopic pregnancies. Actually, the incidence is more in ectopic pregnancy in ART pregnancies, but I'll come to it a little later. If you see the early pregnancy losses, biochemical losses definitely, 4 to 5 times higher than the patient who conceived spontaneously. While the rate and pattern of pregnancy loss following IVF was similar, irrespective to the etiology of infertility. Spontaneous abortions, especially when fresh embryos are used, higher rates were seen with frozen embryos than it was in fresh embryos. Ectopic pregnancies among ART pregnancies varied according to ART procedure types, reproductive health characteristics of the woman carrying the pregnancy, and estimated embryo implantation potential. But heterotropic pregnancies is in 1/100 in IVF pregnancies, while 1 in 30,000 in spontaneous pregnancy. So you can see the higher so much. I mean, there is no comparison of heterotropic pregnancies in ART pregnancy with spontaneous. It is just 1 out of 100. It is 1 out of 100 in IVF, while 1 out of 30,000 in spontaneous pregnancy. So actually, when we do a first trimester scan, we always the early scan, we should always look for, even if you are seeing a live baby, live pregnancy intrauterine, you always look for a pregnancy in both the adnexa, because heterotropic pregnancies are really, really very common in ART pregnancy. If we talk about congenital malformations, in singleton births, ARTs actually was associated with all kind of heart defects, cleft lip, cleft palate, esophageal atresia, and anorectal atresia. But in multiple births, actually the congenital anomalies were same. It was not significantly higher in ART pregnancy. This was actually a very robust studies where the birth defects were studied in patients who conceived naturally or conceived by IVF and ICSI. And it was seen that the overall risk difference was actually not much, whether they conceived spontaneously or by IVF or ICSI. They compared the babies delivered by IVF and ICSI also. So this was a very nice Japanese studies which compared the babies delivered spontaneously, conceived by IVF or by ICSI, and they saw that overall risk difference was not much. And same was in chromosomal abnormalities, including mosaicism. Obstetric complications, if we talk, then we all know that all placental complications like placenta previa, placenta accreta percreta, placental abruption, PIH, pregnancy-induced hypertension, premature rupture of membranes, preterm premature rupture of membranes, gestational diabetes, and rate of cesarean sections. Stillbirth were definitely more seen in IVF in ART pregnancies, 16.2 in comparison to 2.3 per thousand. Maternal morbidity, increase in admission in antenatal periods and NICU were more in ART pregnancies. Actually, preterm birth, low birth weight, and small for gestational age babies. I would tell you one thing. I have seen hundreds of papers, every paper supporting that higher low birth weight and lower mean birth weight in fresh IVF ICSI versus FET cycles. I mean, overall lower birth weight with any ART versus spontaneous pregnancy. There were n number of studies who all support that they have significantly higher risk of preterm birth and low birth weight after oocyte donation compared with autologous IVF pregnancies. This was again a very, very important paper in 2017, which studied a very large cohort of patients, and they say that donor oocyte cycle have more chances of preterm birth and low birth weight rather than with autologous IVF pregnancies. But as such, ART pregnancies have higher chances of preterm birth, low birth weight babies. This is again, I've just given a review of so many articles saying that they have more chances of preterm birth and low birth weight babies. Neonatal outcomes in singleton pregnancies conceived by fresh or frozen embryo transfer compared to spontaneous conceptions. So again, it was seen that fresh but not frozen was associated with low birth weight and small for gestational babies, and both of the pregnancies, whether it is fresh or frozen, were associated with preterm birth. So this is in comparison. If you see that congenital anomalies were almost twice than in natural conceptions, Spontaneous preterm birth before 37 weeks was again 2 times more. Spontaneous preterm birth before 32 to 33 weeks, almost 4 times more. Low birth babies, again 2 times more, and very low birth weight babies, 2.5 times more than a natural conception. So actually you can see that whether it is low birth weight babies or preterm births, they are more in ART pregnancies than in natural conceptions. Now we come on to stillbirth. So stillbirth again is more, the cause is actually not known, but it shows that stillbirths are more common in ART pregnancies than in spontaneous conceptions. Placental issues, whether it is placental previa or abruption, they are more in ART pregnancies, and frozen cycles are associated with decreased risk of placenta previa and abruption. This was again a Japanese study where they compared with women who conceived naturally and who conceived by conventional IVF-ET. And they found that they were at higher risk of placenta previa, morbidly adherent placenta, pregnancy-induced hypertension. They were having more chances of blood transfusion, more chances of ICU admissions, and the babies in an ICU. Now we come to the management part, that what should we do about our ART pregnancies? Bed rest. Should we go for bed rest? No, there is no robust data which is saying that you should go for bed rest to improve pregnancy outcome. Although if you see the prescription of post-ET, post-embryo transfer, you will commonly see the first and foremost is bed rest. But bed rest actually is not required. This was a very nice paper, again Japanese paper, where they have done a systemic, they have done the review of the literature, and they say that there was no evidence that bed rest improves pregnancy outcome in women undergoing ET in IVF cycles. Now the second part comes progesterone. You've seen multiple progesterone, right from oral like dydrogesterone to vaginal progesterone or gel, injectable, maybe aqueous, maybe intramuscular, and on top of that HCG. So whether actually you want to give single progesterone, multiple progesterone, which route, when to start, when to stop, how much to give, and do you want to use estrogen also, and when to stop it. These are multiple papers full of progesterone supplementation. When to start, all of us know, immediately after embryo transfer, and immediately after oocyte pickup, and in ART, in HRT cycles where we are doing donor eggs, we start right on the day of ovum pickup, or maybe just 1 or 2 days plus minus, but not 4 or 5 days plus minus. It has been seen that if the progesterone starting is delayed by 4 or 5 days after oocyte pickup, then it gives a negative impact on pregnancy. So this is, all of us know that we have to start in a fresh cycle where we are doing self pickup on the day of oocyte pickup. If we are doing donor cycles, then when the endometrium is somewhere around 8 or 8.5 and her donor is ready to give eggs on the same day, we can start progesterone. But the condition is that the endometrium should be somewhere at around 8 to 8.5. The blood flow should be good up to the inner layer, and it should be a nice triple layered endometrium. Then we start progesterone. Or I can say when the minimum estrogen days are 10 to 12 days, then we can start progesterone. Now the question comes when to stop. Sometimes you stop it as soon as the cardiac activity is there. That is 7 weeks, 6 weeks, or maybe 9 to 10 weeks. But in HRT cycles, it has to continue up to 11 weeks, maybe 12 weeks, not more than. The self cycles where the corpus luteum is already there, where we have done the pickup in the same cycle, progesterone should not be given after seeing the cardiac activity, because the corpus luteum is sufficient to support the pregnancy. It has multiple corpus luteal cysts which can actually support the pregnancy. So progesterone is needed till you see the cardiac activity, or maybe up to 8 weeks. But in donor cycles where it is a HRT cycles, then this progesterone is needed up to 11 weeks or maybe 12 weeks, not more than that. Now, we come on add-ons. So you have seen the prescriptions. First bed rest, then some folic acid, which is must, then multiple progesterones, and then comes the add-ons. So now actually there is no limit for add-ons, like aspirin. Do you want to give aspirin in all the patients? No. Low molecular weight heparin, unless it is indicated, I think it should not be given. GCSF, there was a time when every patient was giving GCSF in post-ET periods also. SCG, actually it is not needed because it works on corpus luteum, and your corpus luteum in the self cycles is already good, which is secreting progesterone. SCG also goes and stimulates corpus luteum to secrete progesterone. So there is no need to give SCG. If you give SCG, actually it increases the chances of secondary hyperstimulation. IVIG, not needed. Steroids, antioxidants, and so on. There are so many add-ons which are being used. So we have to look for our prescriptions, whether these patients really need these kind of prescriptions. Now, how do you monitor these ART pregnancies? How do you date? Because the LMP, you do not actually know the exact LMP. So you have to do dating. Screening for aneuploidies is very, very important. First trimester scan. The first scan, actually, you look for 1 sex, 2 sex, whether it is the location, whether it is intrauterine, whether it is ectopic, or whether it is heterotopic pregnancy. Everything you have to look. Then, as I said, heterotopic pregnancies are extremely rare in spontaneous pregnancies, but far more common in IVF pregnancy. Then subchorionic hematoma is very, very common in these pregnancies, which we have to see. Mid-trimester, very important is anomaly scan and location of the placenta. Then fetal echo, not required in all the patients, but now it is being done. Then you do the screening for preterm birth, that is you go for cervical length screening. And if needed, then circlas can be given. Then comes the growth scans, as and when required. We see the growth of the baby, whether it is matching the previous scan or not, and the Likert and the Doppler parameters, are they changing in some patients. Routine Dopplers actually not done, but in patients where it is needed, it is being done regularly. Whether we want to go for elective CS or vaginal delivery to be decided according to the patients, and gestational age for termination again to be decided according to the patients. Dating, actually, if we are doing the self cycle, that means we have done oocyte retrieval. Then in these cases, 14 days prior to oocyte retrieval, we can take as LMP. While in donor cycles, according to embryo transfer, 15 days before that, we can take LMP. If the dating, ultrasound dating and clinical dating discrepancy is more than 14 days, then ultrasound date is taken as the correct date, especially in the first trimester scan. That is, the best time is NT&B scan. 11 to 12 weeks scan gives you the perfect dating. Repeat USG after 2 weeks should be done to see the adequate interval growth, which confirms the ultrasound date as the correct one. Screening for aneuploidies, first is NT&B scan, and then we do a double marker. With this, we can, what is the actually problem in screening? Because of SCG, the results are not correct, because if sometimes there is vanishing twin, then also the results are not correct. So you have to look into it. And if it is a donor cycle, then take the age of the donor so that you get the correct information about the aneuploidies. When to screen, when to do amniocentesis, these are all according to the patient to patient. Fetal anomalies in the first trimester can be seen, especially at the time of NT&B scan. Then you look for placenta where it is developing. You look for cervix, cervical length, internal os, and multiple things can be seen at the time of first trimester scan only. And the very important part is that you do PI of uterine arteries to actually predict preeclampsia in these patients. And once you predict preeclampsia, you know that these patients are more prone for oligohydramnios, for intrauterine growth retardation, and for preterm birth and premature rupture of membranes. So you can start equisprint 150 from 12 weeks onwards, because this is the window, 12 to 16 weeks. If you don't start from 12 to 16 weeks, actually you lose the window and you are not giving any benefit to the patient. Then we come to anomaly scan. Anomaly scan, 18 to 22 weeks. Sometimes we do early anomaly scan at 18 weeks and a late anomaly scan at 22 weeks. In some patients, it has to be done. All of us know about anomaly scan. From head to toe. We see the baby, and accordingly, there are some soft markers for the diseases. Sometimes there are cysts, sometimes echogenic kidney, sometimes something wrong in the head of the baby, and so many things which you can see in targeted anomaly scan, which is actually needed for all the patients. It is not that only IVF babies, but yes, we have more chances of anomalies in IVF babies. That is why we want to scan all these patients regularly. Accuracy of mid-trimester scan is 90%, T5 scan sensitivity is 90%. So I would say one thing at this time, that NTNB scan and a double marker gives you almost 85% accuracy that this baby is not a abnormal baby. Then comes the targeted scan, because some anomalies come later. And then you are 90% sure that this baby is okay. But there are some late anomalies which do not come till this time. And that gives you a pain, that gives difficult time for you to discuss with your patient. Because they say that, Doctor Sahab, aapne to wo wala scan bhi karaya tha, that was okay. Then your anomaly scan was okay. Then how come I am having this kind of problem? But yes, these things happen. Congenital malformations, there are papers which say that increase in congenital malformations were seen in IVF and ICSI compared with naturally conceived pregnancies. However, in Australian birth registry, no difference in congenital malformations after existing for potential confounding factors was found. Not every patient is being subjected for fetal echo, but there are patients where there is a history of congenital abnormalities in the family, or in the previous baby, or the fetal karyotype abnormality is there. Then this patient has to undergo for fetal echo. If the patient, there are extra cardiac findings like arrhythmias, patient herself is a case of congenital heart diseases, certain medical disorders, some drug exposure, some teratogens, IVF conceived twins it is must that you should go for fetal echo, or something like you are suspecting twin-to-twin transfusion, then you have to go for fetal echo. Cervical surplus, I think the screening should be done in all the patients. If the length is less than 25 mm, then it is a risk factor for preterm birth. Optimum vaginal progesterone supplementation decreases the incidence of preterm birth. Optimum trials 2019 says that women with short cervix, there is no reduction in preterm birth with progesterone. Cochrane review 2019, short cervical length does not favor preterm birth, and cerclage is only effective in women with history of cervical incompetence. There is no role of prophylactic encerclage in twin pregnancies unless you find a cervical length of less than 2.5 centimeter. There is no role of prophylactic encerclage, because this gives you again chances of spotting, irritation, and these patients go into preterm labor unnecessarily. Growth scans, actually, whatever you are doing routinely is okay, but in these patients, if needed, if there is evidence of growth restrictions, then you have to go for frequent scans. Routine Dopplers are not actually done, but if it is needed, then it is being done. Medical disorders, screening is must, because you have more chances of medical complications in almost 50% of women. And these include mainly hypertensive disorders and gestational diabetes, maybe age-related or maybe because these patients were a case of polycystic ovarian syndrome. Screening of preeclampsia, all of us know that we take blood pressure monitoring, and then nowadays we are taking 110/75 as a cutoff, not even 130/90, 120/80, because we are seeing more and more complications of hypertensive disorders. So this thing should be screened very properly. Then second, as I said, we look for uterine artery PI, and that is again important to look for to actually predict whether this patient is going into pregnancy-induced hypertension. Patients who are obese, patients who are a case of polycystic ovarian syndrome, patients where there is history of hypertension in their family, all these patients are important to screen for pregnancy-induced hypertension, preeclampsia, and these patients should be considered to be at high risk for PIH and should be offered a low-dose aspirin from 12 weeks of gestation until delivery. So this was a very nice paper, increased risk of pregnancy-induced hypertension in young recipients of donated oocytes. So it was seen that the patients who were young, who had premature ovarian failure, they and used donor oocytes, they were actually at high risk of PIH than their counterparts. So this thing to be studied later also, further also, that do they have this kind of association? The young recipients of donor oocytes have more chances of developing pregnancy-induced hypertension. So there may be one high-risk factor or multiple high-risk factors like nulliparity, more than 40 years, BMI, more, as I said, obesity, family history of preeclampsia, or inter-pregnancy interval of more than 10 years. So this is again important that these patients should be considered to look for pregnancy-induced hypertension, preeclampsias, because these patients are prone for having, or somebody like having some kidney disease. She already has a history of chronic hypertension. Yeah, or they have a history of the hypertensive disease in pregnancy, previous pregnancies. These patients are more at risk of developing pregnancy-induced hypertension. Gestational diabetes, although there is increased risk of gestational diabetes in both singleton and twin pregnancy, but it has been seen that these patients may have some background risk of PCOS, maybe like increased BMI or maybe maternal age. Gestational diabetes mellitus, although many countries say that you should not do a universal screening, but in India, at least in our setup, we are doing a single step screening test, which is very good. Whenever the patient comes to you first, we are doing this screening for every patient. We are using DIPSI guidelines, which is very, very simple. And then we follow these patients according to the reports. Cesarean section rates in women who had an IVF are higher. Why? Because of maternal anxiety and patient's preference rather than clear-cut obstetric indications. So whether we should go for elective cesarean section or vaginal delivery depends on patient to patient, depends on doctor, depends on their anxiety. Whether it is a single pregnancy, whether it is a twin pregnancy, whether the woman is more than 35, BMI is more, there is no other high obstetric conditions or febrile cervix, then these patients can go for a vaginal delivery. Vaginal rate delivery up to 50% can be achieved in IVF pregnancies. And if we talk about gestational age, these pregnancies should go up to 39 weeks in the absence of risk factors like IUGR, like oligohydramnios, like change in Doppler parameters. Then, of course, you are terminating this patient before 39 weeks, maybe at 34 weeks, 35 weeks, but otherwise, pregnancies, delivery, whether it is vaginal delivery or cesareans, you have to decide, and the gestational age accordingly. If there is no risk factor, then they should go up to 39 weeks. So what are the precautions to be taken in ART pregnancies? Most of the ART patients become exceedingly elated when the result of their pregnancy test is positive, and the doctor also, because then they feel that their hard work during the tough period has culminated into a fruitful thing. But then these patients do have problems. It is a fact mothers with ART pregnancies are 5 years older than women who conceive naturally. In Australia, the average age is around 36 years, while in India, for self-oocyte, it is around 35, 36, and for donor cycle, it is somewhere between 42 to 45. Antenatal management, formulate plan of care, anomaly scan and serum screening is must. You might need some other softwares to calculate risk factors for ART pregnancies. Monitor cervical length for risk of preterm labor. Increased vigilance, serial ultrasound scans, fetal monitoring in third trimester of pregnancy for fetal growth and well-being. Low dose aspirin for mothers at high risk of preeclampsia before 16 weeks. Gestational diabetes screening is must. The biggest risk for ART pregnancies are multiple pregnancies. Abortion rate are more in pregnancies, in ART pregnancy rather than a spontaneous conception. The increase is due to maternal age, endocrine disorders, polycystic ovarian syndrome, subfertility, ovarian stimulation, and invasive procedures like ICSI and PGD. Sex chromosome abnormalities are partially enhanced due to abnormal sperm injections. Increase in low birth babies are 3 times more. Increased risk for genetic disorders seen in some patients. Lowering the major congenital malformations in severe male factor can be performed by high power magnification selected response. To conclude, 30% women with positive pregnancy tests following IVF will lose their pregnancies before the end of first trimester. 20 to 25% of IVF pregnancies are twins or higher order multiple gestations. Pregnancy complications such as prematurity and intrauterine growth retardation are more often following IVF, even in singleton pregnancies. Single most important factors for poor pregnancy and neonatal outcome is multiple pregnancy. So elective single embryo transfer should be done for all cases to avoid all these problems like preterm birth, increased antenatal admissions, increased admissions in NICU, and giving unnecessary economic burden on the patient. These points should be discussed with all couples planning to undergo for IVF ICSI. So what I say, IVF pregnancies may be different in many ways, but we as physicians should act wisely and take the decisions accordingly. Thank you so much. Thank you for your patience hearing. This is like I keep on doing something on YouTube, and if any questions, I would love to.
Thank you. Thank you, madam. Thank you so much for such a nice lecture. You have covered each and every aspect. Dr. Nishant, can you please check if any questions, please take?
Yes, ma'am. 1 minute.
Yeah.
Faculties member, per participant, if you have any queries, please post your questions in the chat box. No, ma'am, there is no question like that.
Madam has covered each and every aspect. Nothing is left. So what the participants or I can ask, everything madam has covered. So thank you, madam. Thank you so much for giving your precious time and sharing your immense knowledge with all of us. We all academic buddies are really grateful to you, because I run this group with the name of the academic buddies, where we having all the doctors across the geography. So whatever the queries we are discussing here. So thank you once again to all my dear friends who have joined all across the geography. So see you.
Okay, ma'am.
Yeah.
We received 2 questions.
Okay, take it.
From Dr. Shushila Kunte.
Yeah.
Any indication or when to start prophylactic LMWH along with low dose aspirin in ART pregnancy with conceived by donor oocyte?
Yeah. So actually, low dose aspirin, we start where we are suspecting that this patient can develop pregnancy-induced hypertension. Low molecular weight heparin only in patients where APLA was positive. There you can have both the things. Or patient has recurrent implantation failure, recurrent pregnancy losses, but APLA was not positive. In those patients, definitely you can start empirical low molecular weight heparin. Although I am not actually in favor of this, because the studies are very different. Some studies say that yes, you can start low molecular weight heparin as well in these recurrent abortion patients, recurrent implantation failure patients, recurrent pregnancy losses patients. But if the APLA is positive, you can give both the things. You can give low molecular weight heparin also, and you can give aspirin also.
Okay, ma'am. And the second question is from Dr. Yukti Bhardwaj. Is echo recommended in all ART pregnancy, maternal echo?
So I would say one thing, doctor. One thing is that like NT&B scan and TIFA, which is being done in all the pregnancies, whether it is a 16-year-old patient, whether it is a 36-year-old patient. Likewise, if you have some problem in your TIFA, in your anomaly scan, then you can go for echo. Or there was some history of congenital heart diseases in previous child, in the mother itself, or she was exposed to something like Ritugen. But in ART pregnancies, because we have more chances of cardiac anomalies, actually it has not been written. The papers do not support that every patient should go for fetal echo, but it is good for us that we should go for fetal echocardiography. So what we do is we do a NT&B scan at 11 to 12 weeks. 18 to 20 weeks, we do a TIFA, that is anomaly scan. And at 24 weeks, we do fetal echo and late anomaly scan.
Yeah, thank you,
Ma'am,
madam.
Ma'am, I had asked about maternal echo.
Maternal echo, yes. Dr. Yukti, it is a very, very good question. So nowadays, the patients who are around 40 or they have a history of hypertension, this patient is having hypertension continuously, you should go for maternal echo in all these patients. And at the time of oocyte retrieval, go for ECG and 2D echo. And after that, when the patient is having high blood pressure continuously, she is on high doses of antihypertensives, or she is having something like edema all over the body, or she comes with to you with dyspnea, all these patients should be subjected for 2D echo.
Thank you, ma'am. Thank you.
So with this, we will wind up for today. Friends, so connect us on the next Thursday at 8:30 p.m. Next Thursday, we are having an international speaker all the way from the Arab countries. The topic is regarding the ovarian cryopreservation. So I will put the details tomorrow or by day after tomorrow. So see you all again on next Thursday, same time, 8:30 p.m. Indian Standard Time, 5 p.m. Egyptian time. So thank you once again to all of you. Thank you, Shield Pharma, for providing the platform. Special thanks to Nishant and to Sahiti. With this, we will wind up for the today. Bye-bye. Thank you, madam, once again. Thank you.
Thank you so much, Ritu. Thank you.
Yeah, ma'am.